Could you please give the Commissioners your name and your professional address and your current post held, please?
So, I'm Dr. Stephen Mark Spencer, normally Mark Spencer. I have three main roles. I am the Medical Director for Shaping a Healthier Future, the lead clinical director for that programme. I'm a part-time GP, work still at Hillcrest Surgery in Acton W3. My main role is as Deputy Medical Director for NHS England London. My professional address therefore is Southside, 105 Victoria Street, London.
Now, in front of you, you should see a number of bundles. Could I ask you, please, to look at bundle 2, first of all? And if you turn to page 603, you should see in front of you a letter dated the 23rd of February, which you sent to this Commission. Can I ask you to confirm that that's your, true to the best of your knowledge and understanding, and you wish that to stand as your evidence to this Commission? And then in bundle 5, there is a supplementary letter, and I'm sorry, you're going to have to... If you have a look, please, at page 1755, you should see there a further letter sent by you, dated the 18th of March this year.
Yes.
And again, is that your evidence you wish to stand before the Commission? Can I begin, Dr. Spencer, by asking you briefly about your views on the consultation process? Now, we know that the options that were put to public consultation were all based on the reduction from 9 to 5 hospitals as retaining their major hospital status. Do you think, would it have made for a fuller or more open debate if other options had been included? So,
we plan to have 5 major hospitals. They're not retaining, they're being built and developed to become larger and better. 4 other hospitals we intended to become smaller, so that we could localise more care but centralise care where it was necessary to do so. In the consultation we asked for both information around that principle, which was strongly endorsed by the consultation, as well as the particular options around consultation, and there was further opportunity in the consultation for people to propose other models.
Can I just be clear, though, that the models that were put forward were the 3 options, A, B and C?
And as I said before that, there was the principle that whether people agreed with the principles but got to those, and there was strong endorsement of that, and there was an opportunity for people to give alternatives.
So is it your case that, in fact, there was a wider ability, there was an ability to have a wider view put than the options that were put forward?
Indeed, yes.
Given that the 3 options were put forward as preferred options in that way, these were the fleshed out options rather than the ones that invited perhaps comment on a more general basis from members of the public or other organisations, do you think that pre-ruling out of those other options damaged public confidence in the process?
As I said, we didn't rule out any other options.
Can I ask you please to have a look at your letter? It's page 608, volume 2. Now, what you say there on this subject, you talked about the work involved, and you say, despite our best efforts to communicate with stakeholders the benefits which we know this programme will deliver, there remain misconceptions about this programme. Is that an acknowledgement that for whatever reason the communication hasn't always worked as you would have wanted it to?
That's true.
And you're aware, aren't you, that issues about the consultation process, it's one of the themes that's frequently been raised by a number of the campaigning groups involved in this.
Indeed, and it was the reason why the Council referred us for judicial review, which was turned down, and the consultation was found to be exemplary.
Can I ask you please to have a look at another matter in volume 5? It's page 1734, if you would. And what this is the... Sorry.
Thank you for bringing that to our attention. We will try. We'll try and make sure it doesn't happen.
Let's try and see if that works better.
Is that better?
Can I say, one of the difficulties with these hearings is that the way the council chambers are made is it's just simply not helpful for public gatherings, because of course the very nature of what we're considering, so I apologise for that. And please, if there are any further difficulties, do speak up immediately. Now, could I ask you please to look at Volume 5, and it's page 1734. Mm-hmm. And what this is a submission by the Joint Health Overview and Scrutiny Committee. And what they say, and this is there's a section marked consultation period, and what they say is the process of consultation needs to be grounded in a genuine commitment to engage with the public, with staff and with partners from the outset. Is that a sentiment with which you agree?
Of course.
Yeah. And over the page, at 1735, there's a section headed Public Engagement. And what they say there is, whilst acknowledging the efforts made to consult, Josh concludes that the numbers reached directly seem very low. And they point to failures in availability of documents in key locations and community languages. And they also raise concerns over patient engagement and consultation taking place over the Olympic and holiday period. Now, are those issues that you recognise?
No.
Not at all?
Well, first, the JOSC were invited to comment on the duration and timing of the consultation, and the JOSC approved that. We asked them if the length of time was adequate, and the JOSC endorsed the consultation time and period, which is a matter of record. Secondly, there was a 2-week period when there was a difficulty in accessing translated materials. After that period, that was rectified, and public information was available in all local GP surgeries, in libraries, in town halls, in multiple languages, and on our website, and publicised as that. We had a worker working full-time, reaching hard-to-reach groups like small Somali groups, and working throughout Southall and other areas. We worked extensively with groups that helped with translation, so they could reach into areas where there was difficulty understanding English, seeking to attending gurdwaras and temples, a very extensive consultation.
Now, if Josh's concerns were correct, that would be a serious concern, wouldn't it?
I think these are important areas to consider.
Can I just ask as well, because you've gone into this a little bit further in your latter response, and the latter letter that you provided was a response to the Brent Patient Participation Group. You just have a quick look, please, at 1755. And in this, what you're doing is you're talking about the consultation, pretty much as you've just set out. What I wanted to ask you about was this: given the extensive steps that you've just described and that you set out in that letter that were taken as part of the public consultation exercise, why is it, do you think, that there's such a strong and widespread perception that that isn't the case?
I think the timing of our consultation was very difficult. The timing of this whole programme has been difficult because it coincided with wider changes in the NHS that were being imposed by government and were unpopular amongst a wide range of people. There's been a lot of campaigning to save the NHS and to stop privatisation within the NHS, and people have become confused about the various processes in here. I would argue very strongly that what we're doing in North West London is exactly doing those two things, and I would sign up to many of the petitions that have been around to save the NHS because we're exactly having a programme that does that.
Does it trouble you, given that you're obviously very passionate that these are the right decisions, these are the right changes to be made, that some sort of 3 years down the line, after the consultation process, this is still an issue?
It's going to continue to be an issue for a long time. This is a complex change, and we need to continue working very hard to communicate as well as we can.
Do you think now that if changes were delivering the benefits envisaged, some of that concern about the consultation and the lack of communication might have faded away by now?
A small amount of it may have done, I think, because of the timing with the election and the various campaigns that have been going on. That's continued to elevate concerns beyond where they're necessary.
Can I ask you now, can we move on, can I ask you about the business case? First of all, am I correct that there should be a business case for each individual hospital and for each CCG?
Mm-hmm.
and that there's also an overarching implementation business case for the Shaping a Healthier Future programme itself overall.
Indeed.
Can we go back to JOS, please, and can you look at page 1707? And 1708. This is a section marked financial viability and business case. And what's set out there, and going over the page, is a series of requests from the JOS for the outline business case to be shared with the committee. And we can see they're raised, I think, in February, March, this last year, August, and finally March 2015. Are you able to assist the Commission with where the IMBC is at the moment?
It's in draft formation, being informally discussed with the Department of Health and the Trust Development Agency.
Are you able to help with why it's still in draft form?
Because part of the recommendations from the Secretary of State was that further discussion should happen with the local population around Hammersmith and Ealing to help define what a local hospital would be on those sites. That discussion and engagement has continued and helped define that, and that's inevitably put in further time lanes in that. There have been other delays around the merger with Ealing and Norfolk Park Hospital as part of a separate process, and that's delayed their ability to pay attention to this. A series of factors like that.
Do you know when it's going to be completed?
I'm a clinical lead, I'm not a finance lead.
Have you been given access to the draft document?
I've seen an early draft of it, yes.
Are you able to help the Commission with why it hasn't been possible to share that document with this Commission?
It's in early draft formation, as I've said.
Are you able to help with who has made the decision that documentation can't be shared?
It's a implementation plan designed by the 8 CCGs, but it's being shared with the Trust Development Agency and the Department of Health, who have given advice that at this stage in its early development it shouldn't be shared.
Can you indicate by whom you've been given that advice?
I couldn't be accurate with that, no.
Is that something you could find out for us?
I can ask, I don't know whether I can find the answer.
I wonder if we could turn back to your original letter in volume 2 at page 607. Now, you refer at the third paragraph down, it's headed significant progress has been made, yeah, in this area. And you're talking about out-of-hospital services. First of all, you describe the outline business case for the hubs as in development. Again, in terms of that outline business case, is that something you've got access to?
I haven't seen those yet.
Do you know who has got it?
They'll be available in each individual commissioning group.
But the in that case, the one for your area, is that something you've seen?
I'm not working in a particular area now.
Well, as the coordinator of the 8 CCGs, does it not strike you as strange that you haven't seen the outline business case for the hubs?
No.
For all of them?
No, each borough is working locally to develop their local hubs. They are included in the implementation business case, but when I'm reading that, I'm interested in the clinical evidence around the changes that are being imposed, not upon the financial management of individual hubs.
Do you know when those outline business cases will be ready?
No.
Now, if we turn next to the outline business case for investment in acute hospitals across North West London again, is that something you've seen?
As I said, I've seen the overall implementation business case in its early draft.
So, could you say it again?
I've seen the overall implementation business case in its early draft.
But you haven't seen the specific business cases for the hospitals, the acute developments across North London?
They're all included within the overall implementation business case.
So when you refer to the consolidated IMBC being developed to provide a single consolidated view of these investment requirements, is that the overarching one you're talking about? So it's the same one?
Yes.
Okay. At the end of the paragraph, you set out, once the IMBC is agreed, further work can be taken forward. That's right, isn't it? Can you clarify, are you saying that the developments that you set out for the hubs, the acute services, the developments you outline in those 3 paragraphs, can go ahead with the plans still in development, or do they need to wait until the IMBC?
They will be going ahead of the full. The IMBC includes all the investment in all the hospitals. The local development in hubs in the community can happen before that, and it must do.
I wonder, can you help the Commission understand the thinking behind the implementation of these changes on the basis of plans that haven't yet been completed, that are still in draft form?
Because that's the nature of planning within the NHS and the Department of Health. Where the business case, the consultation was made on a pre-consultation business case where we did outline financial analysis. Following that, there's now a wider, more detailed business case that needs to be developed for each site.
Is there a risk that proceeding on that basis might give rise to errors?
There's an opportunity to continually improve our plans.
Is there a risk that it might give rise to errors, though, if the business plan isn't fully formed?
If we didn't have proper procedures to check that things were developing well, then there would be problems, but we have a governance structure that enables us to improve our plans.
So can I take it then that you're confident that there isn't a risk?
So, for example, in the planned changes around maternity, we've been investing in maternity services at West Middlesex, for example, ahead of our plans.
And still on the IBMC, can I ask you to have a look at volume 5 again? It's page 1806. Now, this is the budget for external consultancy from February to December 2014. Can I ask you to have a look, please, on page 1806, there's an item, it says IMBC Assurance.
Katie, can I just interrupt? If anyone does have a mobile, it'd be very useful just to turn it off, or else it'd be as embarrassed as that lady was. She just left the room. So if you could turn your mobile off, I'd appreciate it.
Sorry, Dr. Spencer. You see, it's halfway down the page. Sort of, in fact, it's 1, 2, 3, 4 items, 3 items up. And what it says is assurance support and IMBC, and it says there's a figure of, I think, 1,235,000 to a consortium led by McKinsey's. And then slightly further down, it refers to an item which is for August 2014 over the page, IMBC production, not in original spec. Given that the IMBC isn't yet completed, can we assume that there are going to be further payments required on top of those already made?
I would imagine it's highly likely. I'm not the person to answer financial questions.
Who is the person to ask the financial questions?
The finance director.
It's unfortunate, perhaps, then, that we don't have the finance director here, isn't it?
Well, you could have invited her.
Well, would you be able to ask the finance director if she would be prepared to put in a document addressing these issues?
I'm sure you could do as well.
All right, well, I'm going to continue asking about these items anyway. Can you help the Commission to gain an understanding in terms of the IMBC of why that spend of £1.25 million represents value for money?
As I've explained to you, I'm the medical lead, I'm not a finance director.
Let me take it in short form then, because I suspect your answers to all of these questions are going to be, I can't answer this because I'm a medical director.
That's what you invited me here to answer.
To deal with the clinical matters. Do you think that the £13 million which these consultancy fees amount to represents good value for money for the public?
If we're improving the quality of care and improving the outcomes for our population across North West London, I would imagine this would be an extremely good investment.
Now, one of the issues, moving on, that's generated considerable controversy has been the closure, of course, of Hammersmith hospitals and Central Middlesex Hospital's A&E units.
Mm-hmm.
Now what you say, and in your letter, it's a 605, is that you set out the closures in response to increasing clinical risks. But it was quite a departure, wasn't it, from the original plan?
Indeed it was. It was a recommendation of the independent reconfiguration panel.
And that original plan had envisaged that there wouldn't be any closures of that nature until the out-of-hospital services are much more further advanced. That's right, isn't it?
It is.
Yeah. Now we know, don't we, that after the closures into September 2014, there was a dip, a falling off in performance at North West London hospitals in terms of accident and emergency waiting times.
There was a reduction in performance prior to the closure, which continued afterwards, in line with many A&E departments across the country.
Am I correct that what you say, in your understanding, is this was to do with winter peaks and other variations and was not connected in any way to the closures?
I can't exclude there being a smaller part of it related to the closure. Change inevitably often causes a small deterioration in factors. We've had meetings afterwards to look and see what we could learn, and there are inevitably things we learn when we make changes.
But can I ask you about that? Because there was an analysis put in place, there was an NHS inquiry put in place afterwards to see what had gone wrong. Do you know what process, where that has reached? I
haven't seen even the draft formation of that. My understanding is that there was delays in putting in place some extra beds in Norfolk Park beyond where we had expected them to be. Those were put in place very shortly after the changes, and that helped address the matters.
Just in terms of the report that I was asking about, do you know where that's got to?
It's within NHS England. It's not something I'm involved in.
So again, no idea of when it's going to be completed or when that might be made public?
Again, you'd have to ask NHS England London office for that.
Right. Now turning back to the dipping performance. Now what you say is that despite that, North West London was the highest performing sector in London and above the national average.
Indeed.
That's right. Can I just ask you to look, because I want you to comment on some other people's views of that and see if you can help the Commission understand how people have arrived at these different views. If we look at volume 5 again, and it's page 1860, and what this is from Brent patients' participation group. And what they say is that the last paragraph, and I'll read it out, it's about the 4-hour waiting time. They're talking about your view of the causes for the failures of in A&E. And they say the focus on the aggregated figures for all A&E departments, all A&E patients, included urgent care centres, and this disregards the widely publicised crisis at Northwick Park. Can I ask you whether the figures that you draw your evidence from do include UCCs as well?
Yeah, that is the national target, is to include those figures. There isn't an independent target to meet type 1.
So, can I also then ask you to comment on what is said in that document about the specific situation at Northwick Park Hospital? Is it correct that Northwick Park Hospital, despite the aggregate figures, was amongst the lowest performer for many weeks?
If you were looking at specifically type 1 figures, yes it was, and it is something that we take seriously and have continued to take seriously, and is improving.
Now both the authors of that submission and a number of other witnesses have clearly discerned that there is a causal link. Sorry. Causal modes. Sorry, I beg your pardon. But other witnesses have obviously discerned that there is a causal link. They think there is a causal link between the performance at Northwick Park Hospital and the closure of the other two A&Es. Why is it you say they've got it wrong?
Because as I said, there has been an external review to look at that.
This is the review we don't have yet.
Indeed. But if you look at the figures across North West London, there was a deterioration in figures at Chelsea and Westminster, for example, which had previously been performing amongst the very best in the country. which deteriorated at the same time by a similar scale. It's impossible to imagine that patients from around Brent were travelling down to Chelsea and Westminster to cause the deterioration there. And we saw a similar deterioration across the rest of the country.
And is it your thinking that it was largely about seasonal impacts?
It was very largely about seasonal impact, yes.
So if that's right, one would expect moving into spring and summer that effect would dissipate, wouldn't it?
So you'll find that NHS England's figures and North West London's figures improved in the last quarter as opposed to the quarter before. The only part of the NHS that has done that around the rest of the country has continued to deteriorate. And you'll find that North West London improved faster than the rest of London.
Can we have a look at slightly further on in that volume? It's page 1851.
Katie, before we do that, I've just been asked to make an announcement. I think it's kind of Mr. Patel, owner of a BMW R49 HBD, returned to his car because the enforcement is planning to take it. If Mr. Patel is in the room, he might want to leave. Doesn't look like he is. Sorry, Kate, please.
No. I'm just thinking about poor Mr. Patel for a moment. It's clearly going to blight his weekend. Can I ask you just to look at volume 5? It's 1851. This is a newspaper article, I grant you. But what it says is, this is a recent document, it says, and this is April, all of West London's hospital trusts missed A&E waiting time targets in the last month. Just 18... what I'm going to do after this witness is I'm going to sort of stop for a minute and reconfigure this slightly. Can I ask you to...
After consultation, I hope.
I don't have to. Can I ask you to comment on, please, that figure of 89.2% targets in terms of the missing, not missing, but the Met targets were only 89.2%. So it's right, isn't it, that they're still falling quite short of the targets?
I don't deny at all we've got more work to do.
And you still say that that's completely unrelated to those A&E closures?
I've said there may be a small interrelation, it's not a major factor.
Can we move on? Can we look at the out-of-hospital situation? Now, what you say, your original document, is that each CCG has made significant progress. Can we look at Brent? Now, as I understand it, the out-of-hospital strategy is rolled out in 5 waves. That's correct, isn't it? Brent is rolling out, yes. Can you assist with where that process has reached so far?
You would need to talk to Brent CCG to be specific around the Brent plans.
Are you able to help with any issues which relate to specific CCGs?
In generalisation only.
So if I ask you to comment on what's happened with the Wave 2 musculoskeletal services and the gynaecological services tendering process in Brent, are you able to help with that?
No.
Do you know anything about it at all?
Only the top headlines.
Has anybody brought it to your attention or discussed it with you?
Some of the lay members here have raised it with me.
Has anybody in Brent CCG raised it with you?
No.
Can we go this far? There is still, is there not, a long way to go in terms of rolling out the out-of-hospital services?
Indeed.
Yeah. Now, you also raise the issue of healing maternity, and in your original submission, and it's at 607 if you want to go to it, you set out that the timetable had been accelerated due to concerns about sustainability. At the time of your document, a decision was expected on the 18th of March, and that's also been delayed, hasn't it? Are you able to help with why that's been delayed?
Because one of the things, as I mentioned earlier, one of the problems we had in the A&E changes was we thought a ward had already opened, had been told it had, and yet it was delayed until after the A&E changes. When we found we were planning to make maternity changes, we found that some of the increased maternity services at Queen Charlotte's weren't yet available and ready, so CCG was advised not to make a decision until they could be guaranteed that the premises would be open.
Do you know when a decision will be available?
The CCG are planning to meet in a couple of weeks' time, I think on the 20th, to make a decision about this.
So how does that delay, and some of the delays that I know you can't speak about in detail, but with the Brent tendering, how does that sit with your view that progress is going well?
I'm very pleased with the way that's gone. So some of the changes have happened earlier than we were expecting, some are going slower than expected. This is a very complex process across 8 boroughs, 8 CCGs. We're expecting it to take 5 or 6 years. I would be very surprised if there weren't hiccups along the way.
Thank you. I have no further questions, but if you'd like to wait there may be some questions from the commissioners.
Thank you.
And then with your permission, commissioners, we'll take a break afterwards and shift things around a little bit.
Mr. Spencer, Dr. Hurd is going to ask questions first, then Dr. Lister, and then I may have one after at the end of that.
Thank you.
Can people hear me? Yeah? I was in trouble in previous events for not switching on, especially with my wife, who told me very strongly and reminded me on this occasion. I've got several, Dr. Smith, unfortunately I've got several bees in my bonnet, and I can see familiar faces, and I apologise to them if I press you on certain things. And one of them is about the kind of geography of the area and what is happening. And I have a rather too small a map, so I'll have to do it out of memory. But when I look at the map of the reconfiguration that's going to occur across the whole of the area that you are Deputy Director of, I see St Mary's Hospital to the east, just by Chelsea and Westminster Hospital. And on the other side of St Mary's is University College Hospital. Chelsea and Westminster, a very grand building, trophy building. UCH is a huge, massive building. UCH has its own acute stroke unit. St Mary's has its own acute stroke unit. And I also understand from my own patients, just before I retired, how many services were being transferred from Charing Cross to St Mary's. But I also know, other than one ward in St Mary's, that the most depressed, and the most diverse, and the most deprived areas are to the west, Ealing, in Southall, some in Brent. And yet, most of the services are being concentrated in what some would say are the most privileged areas. If you look at the map, you would think, well, the concentration should be in the middle somewhere. Why do you think that has happened?
So if you look at stroke services, the ones you raised first, stroke services and where they were cited as part of a pan-London process that happened prior to Shaping Health the Future, it recommended that there would be in North West London 2 major acute stroke units. One would be at Imperial, the other would be at North West London Hospitals at Norfolk Park. In the original designation, they said initially it should go to Charing Cross, but when the opportunity arose, it should move to St Mary's to be adjacent to the vascular services and the major trauma unit. And that's what we're able to do with this thing. So it's moving from Charing Cross to St Mary's, but there is also a stroke service and vascular service at Norfolk Park to provide care in the outer parts of North West London. The concentration of population, of course, is different than just the geography. There's more concentrated, higher density in central London. And I agree with you entirely, because of the historical nature of centres of excellence. There are more major teaching hospitals with the clinical codependencies that enable you to run these major services in central London. So major trauma, if you look at them, there's the Royal London, St George's and Charing Cross, all in the centre of London, are not at the outside. And the next major trauma centre along the road is in Oxford, in John Radcliffe. But nonetheless, we know that despite those great distances, they've had a major impact on reducing morbidity and mortality.
But they were at Charing Cross and working very well. You've chosen the stroke unit as an example. And you and I, you as a kneeling GP will know, of course, that
I was
great at Charing
I was trained at Charing Cross.
and it was great at Charing Cross. All the expertise is there, the team is there.
And it will move to St Mary's.
I'm not sure I agree with you about the population either. But UCH has, I'm right in saying, has an acute stroke unit as well.
Yes.
And we were given the argument that, oh, we're moving it from Charing Cross to St Mary's because there's a trauma centre and a neurosurgical unit's going to be there. Although it was at Charing Cross and working very well there. In fact, I'm told it had been the leading world centre, or a leading world centre. But that's going to be moved.
It will be.
Yeah. Whatever teams are going to be broken up and moved.
They will move in blocks, they won't be broken up.
You hope.
That's what they tell me.
Yeah, that's what they tell you. But you know that it doesn't happen that way. But next door, and it is next door, because I don't walk very well, to where University College is, and University College does not have a trauma centre. So you can have one without a trauma centre. So two acute stroke units are almost adjacent. So I suppose what I'm getting at is, why is it St Mary's?
This was the designation of the London Health Programmes prior to Shaping a Healthy Future, not part of this programme.
Well, can't that be changed?
It could be, but we recognise that the benefits of the codependencies with major trauma and with vascular surgery are greater.
Isn't happening next door.
It's not happening at Charing Cross at the moment. We can make it better.
But it was happening at Charing Cross. There was a trauma unit.
There was not a trauma unit at Charing Cross.
Neurosurgery was done there.
Yes, but not trauma.
But neurosurgery was, and if UCH
and there are advantages of
UCH can run one without a trauma unit.
Are you denying there's a benefit of having major trauma and neurosurgery next to each other?
Well, apparently UCH does.
Are you denying there's a benefit?
But apparently UCH does.
And it can be done, and it's less good.
Why can't it be at Charing Cross?
Because of the benefits of moving it.
I'm not sure.
Can I just assure you the Royal College of Surgeons and the stroke unit both agree with me?
Well, maybe they could be wrong. You never know.
It's good.
Pushing that a bit further. If, for example, something did come up that convinced yourself or others that things were not going in the right direction in a particular area, what is the mechanism for change in this project?
So, from a clinical point of view, we have a clinical board which includes the medical directors of all the trusts, some of the nursing directors, pharmacists, and the chairs from each of the CCGs who meet together on a regular basis. We review the data around any changes that are happening, and we make recommendations to the implementation board.
There's a recurring theme in these events has been that there almost seems to be a juggernaut, and which seems to have started, and it's impossible to stop, no matter what argument. Taking it a bit further, I mean, how would the residents, for example, in the west of the area, feel about having to travel in centrally when they're the most deprived, and when in St Mary's and UCH are perhaps the most well-endowed? Which is why we're
developing 5 major hospitals distributed across the area to provide good care close to where everybody lives. At the moment, and in the past,
surely.
Indeed, they could go to Northwick Park, West Middlesex, Hillingdon, and they're all available. At the moment, those hospitals are much smaller and less able to give good care.
And you would call those close hospitals?
I would say they're closer than the major teaching hospitals are at the moment.
I'm not sure others would agree, transport-wise.
It's quite clear where the major teaching hospitals are at the moment.
Can I put this a bit further then? St George's moved to Tooting, and St Mark's moved to Norfolk Park, a great distinguished Bowel Hospital. Major institutions do move. Why couldn't St Mary's move to Ealing, for example?
Because then it would be too close to both West Middlesex and Northwick Park. If you look at the geography of northwest London and were to put 5 hospitals on there, you distribute them much the same as they are at the moment.
I beg to differ. Can I carry on?
With our people in the public gallery, it's not easy for us to follow if you interrupt. It's sometimes difficult, but can you try just to keep quiet? Thank you.
I'm sorry, you've been very good. Thank you, Jason. Forgive me if you can. What do you understand a local hospital will have within it?
Local hospital will have an urgent care centre to provide urgent care. It will have outpatients, diagnostics, some facilities will depend upon the area to provide renal dialysis, chemotherapy, day case surgery.
But no inpatient beds?
It can have some inpatient beds, normally for rehabilitation or for low acuity admissions.
So do you think it's right to call that a hospital? Do you not think it gives a wrong impression? It's an outpatient centre, isn't it?
As I say, it'll do surgery and other things. It's a hospital. There are many of these around the country.
So who would be admitted to such a hospital?
Somebody having day case surgery, somebody who's rehabilitating from a stroke or from other trauma who needs local rehabilitation, somebody who has instability in their social circumstances,
so
needs some support and care before they go home.
So they're going to be rehabilitation units then?
Yes.
There'll be no... So do you not think that's... The public has got the impression when you put local hospital in, that the type of hospital that you go into, say, I don't know, if you have a pneumonia?
I don't think so, no.
Well, we've had a different view expressed to us during this period. Again, if I could ask you about another phrase that's coming up and was used by some witnesses that I think are appearing later today, is this concept of hollowing out services. That I just want to see what you think about it, whether you think it exists. That if you reduce services from a major institution, a successful institution, or withdraw, or even more than that, you say that it's at risk, then by definition it's not used, and then you can say, well, it's not used, so we don't need it. Have you ever thought, does that process exist? Go on.
So I think it's quite possible that when people know that a unit is going to close, it will exacerbate that closure. Part of the success, so Central Middlesex A&E partly failed because of the extreme success of its urgent care centre, which took 85% of the work away, which is not unprecedented around the rest of the country. People haven't attained that, but it meant the activity that was remaining at the Central Middlesex site was too low to allow its success to continue.
But thinking of the role of Central Middlesex, which I understand is a big building to be used.
Indeed.
Why was gastroenterology moved there? It was a major world centre, wasn't it?
As you say, it wanted to be next to St Mark's, the major unit that was at Northwick Park.
It wanted to do that?
It did.
I'm not sure, well, okay, I'm interested to hear that. That's the view. But surely that argument was later used, though the Central Middlesex has no activity, therefore it has reduced activity, there is no purpose to Central Middlesex.
Central Middlesex absolutely has a purpose. It's going to be developed as a major elective centre.
Okay. All right, well, thank you very much anyway.
Thank you.
Yeah, that's it. Okay. Yeah, just a couple of questions, Dr. Spencer. First off, the independent reconfiguration panel obviously gave a limited, a conditional endorsement of what was going forward. That was at quite an early stage, wasn't it? Because the plans that they were discussing and the assurances they were given were based on a much earlier version of the business cases. And the business case, as I understand it from evidence we've heard, is actually looking at a scheme increasing in scale from £190 million originally right up to, I think the latest estimate is up to between 700 million and £1 billion. And the whole scheme seems to have changed. So do you think it's appropriate now that the endorsement that you had from the reconfiguration panel still could be seen to apply to what's currently taking place?
Yes, I disagree that it was done at a very early stage. Certainly the business cases have developed since. So the business case that they considered didn't include either Charing Cross or Ealing, because those were still being designed. Those are the things that increased the figures. Because of the time delays brought in by the IRP, by the judicial review, has meant that the land values have changed and hence the increase in costs. But the overall plan of what's being designed is exactly the same.
But the business cases still haven't been put forward, have they?
As I say, they're in draft formation at the moment.
I mean, as a doctor and a clinician, I mean, you work on the basis of evidence, presumably, and wanting to know what the outcome's going to be before you start an intervention. Shouldn't it be appropriate to have the business cases finalised before hospital closures and changes are taking place?
You'd have to change the planning cycle of the NHS, which is not something I can do.
No, but I mean, if the business case is not in place, is it appropriate to start major components of that business case in advance of knowing what the full business case is going to be?
The things we're doing at this stage are implementing out of hospital, which we need to do prior to the business cases.
Okay, on the out of hospital thing, I mean, presumably you are following the developing evidence on the question of out of hospital services replacing and supplementing hospital care.
Indeed.
And you saw the work by the Nuffield Institute, Bardsley's research for the Nuffield Institute, which surveyed a range of community-based interventions and came to the conclusion that the impatience in the system to show changes on what might be an unrealistically short timescale was a bit of a problem. I mean, given that we still haven't got the community services in place, do you think it's still appropriate to press ahead with hospital reductions in hospital services?
We've currently said we're not changing hospitals until we have effective community services, and that's still our intention.
But you are pressing ahead with the closure of Ealing maternity, most likely, when the CCG meets. I mean, this has been postponed rather than halted.
And the alternatives for that have been put in place already.
And you're convinced that the population of Ealing, with all its social problems and mobility issues and so on, will be satisfactorily served by hospitals in West Middlesex, Hillingdon and Northwick Park?
For their maternity services, yes. The majority of their care will continue and increase in the community closer to them.
So more home births in Ealing?
A small amount of more home births. There's room for more than that, but we recognise the growth of that is likely to be very slow. But the antenatal and postnatal care, which often at the moment means travelling to hospital, will happen in community centres and child centres, which are closer to people.
You say in your evidence that the closure of Ealing was brought forward because of the concerns over the quality of services and issues there. I mean, there's two possible responses to that, isn't there? One is to address those problems by increasing the investment there and developing the service to maintain a provision. And the other is obviously to close it down. I mean, given the uncertainty that's been generated over this period of time, don't you think possibly investment in that service, which has already been there and is well established, a very substantial service, would have been a better way forward? So
the key thing that needs investment in is staff, and the key reason why there's a failure to progress in quality of services at Ealing compared to elsewhere is their inability to attract new staff. So the standards across London, which are an improvement on current, is that we should have a consultant obstetrician on the labour ward day and night, 24 hours a day, 7 days a week. So 168-hour consultant cover. At the moment, Ealing is doing that for 60 hours a week. If you go 2.5 miles down the road to West Middlesex, it's at 140 hours, and in 6 months' time they'll be at the 160 hours. That means that women there are getting a substantially better quality of care than is able to be delivered at Ealing. Ealing had vacancies, they've advertised for them, and are unable to fill those posts. It's inevitable that if you're a local GP, you will start referring to people where there's a demonstrably higher quality of care. And that done, you could call that hollowing out, you could call that building a better service and enabling people to choose that.
Well, you could call it making it very unattractive to apply for a job in a place that's known to be on the brink of closure. But just finally, one other question, which is about this whole question, which is the Commission on Hospital Care for Frail Older People, which was, I think, run by the Associated with Health Service Journal. And they came up with this was last year, 2014, there was a myth that providing more and better care for frail older people in the community, increasing integration between health and social care services, and pooling health and social care budgets will lead to a significant cashable financial savings in the acute hospital sector and across health economies. The Commission found no evidence that these assumptions are true. Do you have any assumption that these assumptions, any evidence that these assumptions are true?
I'm very glad you raised that, because it's quite clear that we're making these changes for clinical improvement, not for financial changes. There isn't good evidence that community services are cheaper, and this programme isn't designed to be a cheaper programme. We're continuing to invest in healthcare, because what we do know that improves care is 24 hours early consultant assessment. The more senior the person assessing a patient earlier gives better outcome. It's improved by having good nursing available more often, and it's improved most by having good, higher quality general practice. And those are things we're intending to invest in and enable.
Okay, just one inevitable final follow-on question then. If you're investing all this money, given that we're, the best offer that we had during the election for the future funding of the NHS was a baseline, a continued freeze on real terms funding over the period of time, where is this extra money going to come from?
It's by redesigning the way we work, enabling GPs to work in networks of care, which can provide weekend access and other services. And it's by working more integrated with community and hospitals working together, which is more efficient. It reduces the number of readmissions, which are expensive in monetary terms, but immensely more expensive in terms of personal cost.
There's obviously a long debate to be had. Thank you very much.
Can I just ask you one question? Could I ask you to look at page 680 of your bundle?
680.
608.
Thank you.
It's a document we've already looked at.
Yes.
The last but one paragraph, I can just read it to everyone. You say quite properly that local clinicians have worked tirelessly to agree and deliver changes that we know will result in better care for our patients. And you go on to say that change in the NHS often raises concerns, and this programme, by which you're talking about Shaping a Healthier Future programme, has understandably met with significant opposition from a range of stakeholders who are concerned about the future. My question is this: which of the concerns about the programme that have been raised do you think are the most understandable?
The most understandable? People are concerned that I think probably access is the thing that most concern people and most worries people. There's a myth that having a hospital close to you improves outcome. There's no evidence whatsoever that having a hospital close to you is better for you. So that's a myth that is propagated regularly. I think that's the most understandable. The one that is most evidently incorrect is that somehow this is running down the NHS to make it privatised. Clearly, by improving the NHS locally, we make that less likely, but it's not what the campaigns are saying.
So you've given two examples of the most understandable concerns, and you've dismissed them both pretty robustly. Are there any concerns that have been raised that do concern you?
I continue to be concerned about all the things that are raised, listen to them and try to understand if there are basis for them rather than anxiety.
And with that, are you saying that there's no basis for any of the concerns?
We continue to monitor them very closely.
That's not an answer to my question. I'll ask it one more time. Are you saying that there's no basis for any of the concerns?
I haven't found a basis so far, no.
Thank you very much.
Thank you.
Appreciate you coming to give evidence.
Not at all.